day, we can all stay healthy, and no one suffers from hunger. We will only realize this vision together. Together, we will come back stronger. Together, for a future with health for all, hunger for none.
My journey continues, and I know I'm not alone. Because together, we can make a difference every day.
Good morning. It is time to work. We start now. Welcome to the second day of the 14th Congress of Asci 2021. Hope we will have a successful day with quality topic and excellent speaker, four speakers from the 3.3 around the world. Please allow me to introduce myself. I'm Dr. Nguyễn Quốc Dũng, Vice President of Vietnamese Society of Radiology and Nuclear Medicine, Head of Imaging Department at Stair-Step Hospital in Hanoi, Vietnam. Good morning. I have the honor to introduce to you my co-chairman, Dr. Akira Kurata. From Japan. Now he's the Chief Cardiologist of the Cardiology Department at Shikoku Cancer Center in Japan. In this section, there are four topics. Each topic has 20 minutes maximum. Discussion and question answer will take place at the end of the section with the speaker, with the faculty member and attendee. So first, I would like to invite Dr. Akira Kurata to present the topic. Dr. Akira Kurata. Now, he is Chief of Cardiologist of Cardiology Department at the Shikoku Cancer Center in Japan. His specialty focus on cardiac CT perfusion, CT-FFA, EFR, cardiac function, coronary artery, territory mapping, and 3D printing. Now he works in clinical management of cardiovascular medicine and imaging since 2021. His topic is cardiac CT machine update. Please, Dr. Akira Kurata.
Thank you very much for your kind introduction. I am very honored to have the opportunity for my presentation in this excellent meeting. I would like to talk about cardiac CT machine update. I have no conflict of interest related to this presentation. This slide shows the outline of my talk. I would like to talk about current CT, next generation CT, including ultra-high resolution CT, photon counting detector CT, and phase contrast CT. Non-invasive assessment of cardiovascular disease has been a great challenge in diagnostic imaging since the introduction of multi-detector computed tomography. Technological advances in cardiac CT, such as wide coverage for whole heart imaging and improvements in spatial temporal and contrast resolution allow implementation of the CT assessment in clinical practice. Current MD-CT allows the gantry rotation speed of 240 milliseconds with Echocardiography using single detector system. The highest temporal resolution of 66 milliseconds with Siemens dual source CT system, and the isotropic spatial resolution of approximately 0.25 to 0.5 millimeter. Nowadays, coronary plaque size and distribution are frequently measured using coronary CT angiography because the quantity of coronary artery plaque affects patient outcomes. This is a sub-study of the Scott Hart trial regarding CT coronary plaque assessment. The graph shows the impact of the presence or absence of one or more adverse plaque on future cardiac death or non-fatal myocardial infarction. We can see that CT coronary plaque assessment is very crucial. First of all, I would like to talk about ultra-high resolution CT. As you know, clear visualization of small vessels and the small plaque features are limited because of the spatial resolution of the standard cardiac CT. The only currently available CT system for ultra-high resolution imaging is the Aquarium Precision CT platform by Canon Medical System. This CT system reduces the minimum detector element size up to 0.25 by 0.25 mm compared to 0.5 by 0.5 mm of the previous Canon CT detector element size. This slide shows the digital artery of the foot. This is not a cardiac CT, but subtraction CT angiography using ultra-high resolution CT clearly demonstrates the digital arteries of the foot in greater detail. This slide shows a case of the coronary stent of 2.5 mm in diameter from the clinical study using ultra-high resolution CT. In ultra-high resolution CT, the instant lumen is clearly visible, but in conventional resolution CT, it is difficult to see. In the 2021 SCCT Expert Consensus document on coronary CT angiography, it is appropriate to perform coronary CT angiography in symptomatic patients with intracoronary stent diameters greater than 3.0 mm. This is because previous studies using the standard 64-slice MD-CT system reported that stent size less than 3 mm are less likely to be evaluated, showing the right figure. However, the recent clinical study using ultra-high resolution CT showed that although 25% of stents with a diameter of 2.25 mm were accessible, 90.1% of the stents with a diameter of 2.5 mm and more are accessible. Ultra-high resolution CT is also feasible for coronary artery calcium volume measurement. This slide shows a preliminary Photon and Kevada study for coronary artery calcium volume measurement using ultra-high resolution CT. The table shows the mean volume and error value of calcifications. The mean error value in normal resolution mode and the super high resolution mode was 20.1% and 40.0% respectively. The mean error value was significantly lower on super high resolution images than normal resolution images at each classification density and size. The smallest and lowest density classifications were not detectable on normal resolution images, but all classifications were clearly detectable on super high resolution images. Figure 5 is a representative case. On the scan obtained in the super high resolution mode, small spotty classifications were clearly identified. Regarding tissue characterization, cardiac CT has not yet established quantitative tissue characterization compared with cardiac MRI. Current cardiac CT uses various dual energy-based technologies for quantitative tissue characterization, shown in this slide. In current cardiac CT, using dual energy imaging techniques, calcification-suppressed material density images improve the diagnostic performance for calcified coronary artery lesion in patients with relatively low heart rate. And using current dual energy techniques, virtual monochromatic images optimize the visibility of infarcted myocardium with CT rate iodine enhancement. On the left, the images show rate iodine enhancement of a 75-year-old male with multiple coronary revascularizations. The left panel shows the conventional 40-cave monoenergetic reconstruction, while the right panel shows the 40-cave reconstruction with the optimized algorithm that we call monoplus algorithm. The optimized monoenergetic reconstruction has less noise and appears to show more detail. A lateral wall infarction is clearly seen. On the right, the graph shows contrast to noise ratio, CNR for human chronic myocardial infarction. CNR between infarcted and non-infarcted myocardium is shown for 90 kVp, mixed 90 kVp, and 150 kVp iodine map and monoenergetic reconstructions. Highest CNRs are found in monoenergetic 40 kV optimized reconstructions. Next, we will move to talk about photon counting detector CT. Photon counting detector CT is a cutting-edge form of spectral CT. On the left, in a conventional energy integrating detector, an X-ray photon strikes the scintillator. A shower of secondary visible light photon is generated. The semiconducting material measures the number of incident light photons and generates electrical signals proportional to the total energy rather than the energy of individual X-ray photon. In contrast, on the right, the photon counting detector does not require a separate layer to convert X-ray into the light, but consists of a single thick layer. The X-ray photon absorbed in the semiconductor material generates positive and negative charges. Photon counting detector thus convert individual X-ray photon directly into an X-ray signal. The left figure shows a diagram of the operating principle of a photon counting detector. The detector counts a number of pulses with a height larger than a preset threshold. Furthermore, shown in the right figure, by comparing every pulse to several threshold levels, the detector can sort the incoming photons into some energy beams, depending on their energy. Thus, electric noise is effectively excluded from photons. The left figure shows a diagram of the three material decomposition method by water, calcium, and contrast agent having a K-edge such as iodine or gadolinium. The right figure shows a process of material decomposition imaging. Energy-selective images are generated from the number of registered count in each energy beam. We can create the final color-coded material concentration maps showing different materials using a set of material concentration maps from these images. This slide shows the sample result of multi-material decomposition images of the kinin heart using photon counting detector CT. From A to C, iodine concentration map, gadolinium concentration map, and non-contrast map. The iodine concentration map shows the first pass of blood pool images, and the gadolinium concentration map shows the lateral enhancement of subendocardial infarction with the arrows. In comparison with figure D of a conventional synchro energy images with photon counting detector CT, figure D of multi-material concentration map obtained by combining the material maps shows the differentiation among infarcted myocardium, remote myocardium, and the blood pool with a high contrast to noise ratio. This table shows the ongoing photon counting detector CT project targeted toward full volume clinical CT. We need a lot of time to update the detail in photon counting detector CT, such as spatial resolution, noise reduction, crosstalk, pileup, and alternative contrast agent exploration. If you are interested in this topic, the review article by Dr. Wilming Radiology 2018 is very educational. The last topic is phase contrast CT. Phase contrast CT uses either the organized changes in the X-ray phase or refraction instead of attenuation, and reveals different tissue characteristics, especially in soft tissue contrast resolution compared to attenuation-based CT. Coherent X-rays through grating 1 form a self-images at a certain distance we call Tabot distance. We can obtain the phase images as a deformed molar images by overlapping the images at grating 1 and grating 2. In phase contrast CT, synchrotron radiation can be used as strong X-ray with aligned waves. The upper figure shows a 3D visualization of human cardiac conduction tissue in whole heart specimen by high-resolution phase contrast CT imaging using synchrotron radiation. However, synchrotron radiation is not suitable for clinical application that place importance on versatility. The lower figure is a panoramic view of the synchrotron radiation facility, Spring 8, in Japan. Regarding cardiac application of phase contrast CT, most research groups have performed partial histology by comparing phase contrast CT of coronary and carotid atherosclerosis with histology. These studies identify high-risk plaque features and quantify plaque components with excellent correlation with histology and spatial resolution around 10 micrometer. This slide shows the summary of next generation CT. Ultra-high resolution CT is currently available in clinical practice and achieves 0.18 mm of pixel size. Photon counting detector CT is a promising technique to enable highly spatial resolution, multi-contrast imaging, and improve material decomposition while creating opportunity for quantitative imaging. Phase contrast CT is available in research, but improves spatial resolution and allow better material decomposition and soft tissue characterization. This slide shows take-home message from my talk. Ultra-high-resolution CT is available now, and photon counting detector CT and phase contrast CT are very promising, but require further development and validation for clinical application. Machine update in next generation CT continues to expand and have the potential to bring cardiac CT to the next stage. Thank you very much for your attention.
Thank you, Dr. Akira Kurata. His topic very excellent and update. Focus ultra high resolution CT, photon counting detector CT, and phase contrast CT. And now, ultra high resolution CT is available now. Okay, thank you. We discuss Asci and obsession. Dr. Akira Kurata, please.
Can you hear me? Yes. Yeah, I'm Akira Kurata. Yeah. Next, I am very honored to introduce Dr. Kyusek Chu. He is a professor of the Department of Radiology, Busan National University, Yongsan Hospital. His specialty are cardiovascular imaging and breast imaging. Dr. Chu belongs to the Korean Society of Radiology, Cardiovascular Imaging, and Breast Imaging, and Asci. And I am so impressed his great works about the pediatric cardiac CT guideline, magnetic resonance imaging, myocardial imaging, and mitral loop circulase annuloplasty using CT guidance. And today his topic is avoiding artifact, image reconstruction, and post-processing. Dr. Chu, please.
Thank you, Chairman. I wanted to make a face-to-face presentation in front of a distinguished audience, but I regret that we met through the video lecture due to the COVID-19. Prior to the presentation, I announced acknowledgement. Eunju Gang, Dongwon University Hospital, South Korea, and Jeong-Im Jung, Cardiac Medical Center, South Korea. Definition-wise, artifact means misreading or confusing alteration in data or observation, commonly in experimental science, resulting from flaws in techniques or equipment. Reconstruction means the process of unplugging images from raw data. We need to perform optimal reconstruction protocol and window to get diagnostic acceptable image quality. We need to also optimal post-processing to avoid artifact. Therefore, we can diagnose correctly. Post-processing means that can be sent to various software programs for proper reading images. There are various kinds of post-processing: transaction imaging, bone rendering, multiplanar information, maximal intensity projection, and curved MPR and vessel analysis. Artifacts in cardiac CT include patient-related, procedure-related, and miscellaneous. So, I will present various kinds of artifacts depending on different origin. Patient-related artifact can happen from obese patient, insufficient breath hold, movement, and dense calcium or metal. This is an example of a high-nose cardiac CT. In case of a large, that is obese patient, we needed to use relatively high KVP, Only then we can obtain clean image without noise. High noise image can make us be confused for evaluation of coronary artery stenosis. Left image shows high noise image and right image does not have noise. Why did we adapt higher radiation for obese patients? Higher level of image noise can happen because of inadequate number of photons. We need to use high kVp, high MA, larger voxel size, larger FOV, thickened thickness, and prolonged scan time to decrease noise. Recently developed noise minimization reconstruction algorithm, iterative reconstruction, and deep learning based reconstruction algorithm. Two reconstruction algorithms are widely used for improvement of image quality. From my experience, deep learning based reconstruction algorithm slightly superior to iterative reconstruction for noise reduction. Optimal enhancement is also important for accurate diagnosis. In case of poor enhancement, signal loss and causes inaccurate coronary artery stenosis diagnosis. In case of over-enhancement, blooming artifact can happen and coronary vessels confound detection of coronary flat. Optimal enhancement range of cardiac CT for evaluation of coronary artery is from 250 to 400 hospital unit. Some investors suggest the body surface area adapted CM bolus and rate for constant enhancement regardless of body surface area. If this proposed protocol is applied to the cardiac CT, constant enhancement will be obtained as follows. Respiration motion artifact is a kind of a frequently seen artifact for evaluation of cardiac CT. At least 10 to 13 second breath hold are mandatory for scan. Teaching and practice should be proceeded then scan. Right image shows blurring of the right coronary artery. Coronary reconstruction image in the same patient show discontinuation throughout the heart and the lead from respiratory motion. This is another example of respiratory motion artifact. Coronary arteries appear to be interrupted by an artificial line in the respiration motion artifact, and here and here. Gantry rotation time must be low. Slice per rotation, slice thickness and pitch must be elevated for shortened acquisition time to avoid the respiratory motion artifact. Shortest acquisition time should be selected, especially for severely dyspeptic patients. Single heartbeat scanning with dual source high pitch helical mode is a kind of solution for shortest acquisition time. Practicing for patients also help in elevating heart rate change with breath hold. If heart rate change is ostensible, it may have to initiate breath holding a few cycles before starting the scan. High heart rate is the most common cause of motion artifact. Remedy for high heart rate before the scan is as follows. Use beta blocker and use high temporal resolution and choose optimal acquisition window. In case of less than 70 ppm, mid-diastolic phase is optimal. In case of more than 70 ppm, late systolic phase is optimal. Remedy for high heart rate after CT scan is using multiple phase reconstruction depending on high heart rate during the scan. This image shows artifact versus PET comparison in same patient with a different high heart rate. In case of a high heart rate, Pseudostenosis can be seen in 70 bpm. In case of 60 bpm, we can see the clean coronary artery without stenosis. This is an example of optimal phase selection in same patient with a high heart rate. If we choose incorrect phase for evaluation of a coronary artery, we cannot interpret correct stenosis degree. In this patient with a high heart rate, late systolic phase is optimal for evaluation of a coronary artery. In light image, we can see clean coronary artery without significant stenosis. We can use late systolic phase in patient with 80 ppm. A kind of cardiac motion aspect is as follows: blurring, ghosting, and winging. Mixed blurring with double contour artifact and stair-step artifact are also a kind of cardiac motion artifact. Generally, beam hardening is caused by polychromatic nature of X-ray beam. Low energy photons are frequently observed. Beam passing through a high attenuated object is excessively hardened. Hardened beam, so there is many high energy photons produce much visible light in detectors. Reconstruction algorithm assumes X-ray beam passed through low attenuation object, result in artificially low CT values. Example, dark spot and stripe adjacent to highly attenuated spot. For example, low density sharp line from high density contrast is a kind of beam hardening artifact here and here, and it can make an incorrect diagnosis for cardiac CT. So beam hardening artifact from RA caused by contrast media make pseudostenosis of RCA, and we need to use multiply protocol such as 3-phase protocol to decrease iodine density in RA and overcome beam hardening artifact. Generally, to overcome beam hardening artifact, we need to use high tube current and tube voltage, decrease slice thickness, and use sharp kernel, a sharp high resolution kernel. But a disadvantage of sharp high resolution kernel is increased noise and resulting in low instant attenuation value. Metal artifact is manifested as a street artifact from stent, pacemaker, and surgical clip. Density of metal is beyond the dynamic range of CT numbers. It is an incomplete attenuation profile that cannot be adequately reconstructed. This patient underwent a pacemaker procedure. Metal tips are located in RA and RV. These complicated artifacts interfere correct diagnosis of coronary stenosis, and here and here. I'll show you the interesting slide. Left figure is coronary artery CT. Right figure is the catheter angiography. The presence of calcified flow reduces the ability of differentiate significant stenosis from insignificant stenosis on coronary CT angiography. This is an example of blooming artifact from dense calcification. Pitch-related artifact can happen. Pitch must be set according to the heart rate. Higher heart rate, higher table speed is needed. Low heart rate, slow table level is needed. If pitch is too high for heart rate, get gaps in data, bending artifact. So we need to use adaptive pitch or wide detect to avoid this artifact. This is an example of bending artifact. If the patient have bradycardia, you can see the bending artifact here and here. The volume rendering image shows pseudo obstruction of left coronary artery. Okay, another pitch-related artifact is a stair-step artifact, so-called from misresolution artifact. It is caused by non-optimal page selection. This is not reconstructed at exactly the same page of the heart cycle. This is editing and the beta broker and why the detector can be a solution to overcome this artifact. Okay, this is an example of stair-step artifact. Stair-step artifacts are associated with a high heart rate variability. With irregular heart rate, page misregistration can occur when data from different cardiac phases are used for the reconstruction. A stair-step appearance here and here, resulting from the data reconstructed from different cardiac phases. Another common cause of artificial stenosis is where a small partially opacified vein may close the artery under investigation. It has been our experience that this can cause a loss of attenuation within the vessel of interest that may mimic sort of plaque. L6 looks like a severe stenosis with the soft plaque, but cardiac vein crosses over artery and it causes pseudostenosis of L6. And the magnification view, so pseudostenosis can be seen by vein. In summary, motion artifact manifests as blurring, double contour, stair-step due to partial volume effect, misregistration. So remedy of this artifact is using high temporal resolution, optimal page selection, breathholder practice. Dense object causes a streak and a dark band artifact. It is due to beam hardening. So remedy of this artifact is using high KVP, sharp cornea, etc. Dense object can also cause blooming artifact, and it is due to partial volume averaging. Remedying of this is adjusting window width and level and using high KVP and sharp cornea, etc. And finally, bending artifact can be happened by missing data from incorrect pitch selection. A remedy of this is using adaptive pitch and the wide detector. Thank you for your attention.
Thank you very much, Dr. Cho. He gave the systemic lecture regarding the various factors influence to the image noise and artifact in data acquisition, image reconstruction, and post-processing. Dr. Cho, thank you very much.
Now I would like to invite Dr. Sun-Min Koo from Korea to present his topic. Dr. Sun-Min Koo, now he is head professor of director of Department of Neurology, Yonsei University, Yonsei College of Medicine, Yonsei Civil Christian Hospital. His specialty focus in cardiovascular imaging. A professor application, deputy editor of Journal of Cardiovascular Imaging. He have more than 50 scientific SCI published as a first author. His topic is for the evaluation of valvular disease. Please, Dr. Sun-Min Koo.
Good morning. I'm very pleased to talk about for the evaluation of valvular heart disease using cardiac CT, mainly focus on the aortic valve disease. Moderate or severe valvular heart disease are associated with a significantly reduced survival. The prevalence of valvular heart disease increases significantly with age, aortic stenosis is the most common valvular heart disease and require valve surgery or transaortic valve implantation. Only diagnosis of significant valvular heart disease is the real key to improving patient prognosis. Let me show you a typical case of age-related degenerative tricuspid aortic valve stenosis. As you can see, cardiac CT show second and calcified aortic valve curve with severely limited opening during cardiac cycle and typical mid-wall delay enhancement in LVR on cardiac CT and MRI. To diagnose and manage a patient with or presumed to have a valvular heart disease, imaging can be used to assess valve morphology, valve function, ventricular function, and additional information. Much of this required information can be obtained using cardiac CT. Echocardiography is the typical standard diagnosis modality for assessing valvular heart disease and the impact of ventricular function. However, echocardiography is an operate-dependent method, and poor acoustic window and suboptimal patient habitus can compromise image qualities. Cardiac MRI has several advantages over echocardiography, such as unlimited image plans, high inter-study reproducibility, and quantitative information, especially for regurgitation with bank CMR. However, cardiac MRI has significant limitations to be used widely. For the last 20 years, the application of cardiac CT has expanded to a comprehensive evaluation of valvular heart disease. Valvular calcification and dysfunction, aorta abnormalities, coronary artery anomaly or stenosis can be evaluated at the same time with the cardiac CT. However, cardiac CT has several limitations to be used in daily routine practice. Particularly, cardiac CT is not able to provide functional information about valvular heart disease severity. Cardiac CT is mainly used for coronary evaluation before cardiac valve surgery. This slide shows degenerative aortic valve stenosis with calcification, significant stenosis in proximal artery, and aortic arch aneurysm at the same time. Cardiac CT is thought to be appropriate in use for characterization of native and prosthetic cardiac valves in patients with suspected clinically significant valvular dysfunction and inadequate images from other non-invasive methods, and anatomic assessment before transaortic valve implantations. In patients with rheumatic mitral stenosis, cardiac CT allows for measurement of mitral valve opening area using planimetry at diastole and the presence of thrombus in the left atrium on both the early and the 3-minute delay phase CT. Today, I will only talk about cardiac CT application for aortic valvular heart disease. This slide shows how to comprehensively evaluate aortic valve disease using cardiac CT, including aortic valve calcium scoring and grade, valve morphology, measurement of aortic valve area and regurgitated orifice area using planimetry, and assessment of ascending thoracic aorta and left volume measurement. For the CNA imaging of cardiac CT is useful for the evaluation of complex aortic annular anatomy and the dynamic changes, aortic valve dysfunction, mechanical and bioprocess aortic valve dysfunction, aortic valve mass, dissection, flap extension into the aortic root or coronary artery, and the mobile aortic thrombus. However, for this CNA cardiac CT might not be applicable to routine clinical setting because of higher radiation exposure. There are two CT acquisition protocols for the evaluation of valvular heart disease. First protocol consists of retrospective ECG-gated cardiac CT and subsequent non-gated thoracic aorta CT for reducing radiation exposure. However, this protocol requires longer scan time. Second protocol is retrospective ECG-gated thoracic aorta CT for the evaluation of aorta and heart at the same time. However, this CT protocol has a higher radiation exposure due to wide scan range compared to heart and subsequent aorta CT protocol. Accordingly, I recommend combined cardiac CT and subsequent non-gated aorta CT for evaluation of cardiac valve and thoracic aorta and coronary artery simultaneously. I would like to introduce the role of cardiac CT in aortic valvular heart disease. First, cardiac CT is useful for the evaluation of valvular calcification. CT is superior other modalities for the detection of valvular calcification. In this case, cardiologists diagnose vegetation in the aortic valve based on echo findings. As you can see, mobile valvular calcification is easily diagnosed on cardiac CT. Caroline demonstrates aortic valve calcium scoring using CT was well correlated to aortic valve area and the mean pressure gradient, and the threshold of 1,651 Egerton unit correctly differentiate patient with severe aortic stenosis from non-severe aortic stenosis in patient with a low ejection fraction. In our study, aortic valve calcium score was a predictor for severe aortic stenosis with AUC of 0.8 in both men and women. Its cutoff value was 1,423 Egerton unit in women and 2,573 Egerton unit in men for the diagnosis of non-severe versus severe aortic stenosis. As you can see, 51-year-old man with a pure varicose aortic valve had a high valve calcium score and severe aortic valve stenosis with peak aortic velocity of 5.2 meter per sec and aortic valve area of 0.9 square centimeters. Severe aortic stenosis is usually defined as a peak velocity above 4 meters per sec and aortic valve area less than 1 square centimeter. In case of discordant or poor acoustic window, CT aortic valve calcium scoring threshold accurately identify severe aortic valve stenosis and provide powerful prognostic information such as aortic valve displacement and death. In patients with severe aortic valve stenosis, myocardial fibrosis is significantly associated with more calcific aortic stenosis in our study, as you can see. There is increasing evidence that the presence, extent, and the distribution of calcification in aortic valve, sinotubular junction, and the aortomitral curtain have a role in the occurrence of peri and post-procedural complication of TAVI, such as paravalvular aortic regurgitation, annular rupture, inadequate device fixation, or cardiac embolism. Second, cardiac CT is useful for differentiation of valvular morphology. CT is accurate for identifying aortic valve morphology compared with echocardiography. Echocardiography shows typical Melissus bench appearance in diastole, consistent with the tricuspid aortic valve. However, CT and the MRI show calcified cusp with bicuspid aortic valve. A calcified bicuspid aortic valve with a LAPE was confirmed at the time of surgery. CT proved superior in characterizing the morphology of aortic valve with better differentiation between quadricuspid and tricuspid aortic valve. As you can see, echocardiography shows typical tricuspid aortic valve, but CT shows quadricuspid aortic valve with two equal larger cusps and two unequal smaller cusps. Differentiation between the LAPE in bicuspid aortic valve without elliptical shaped orifice and a degenerative commissural fusion in tricuspid aortic valve is challenging with echocardiography and CT, particularly in patients with severe valvular calcification. Cardiac CT features favoring bicuspid aortic valve include uneven cusp size, uneven cusp areas, round-shaped systolic orifice, longer cusp fusion, and dilatation of ascending thoracic aorta in our study. Cardiac CT provide global average systolic function. CT measurement of global LV function using threshold-based technique or highly reproducible and compare the more favorable with CMR measurement using Simpson's method than those of 2D transthoracic echocardiography using the modified Simpson's method in our study. Cardiac CT enables accurate quantification of global left ventricular function in patients with valvular heart disease. Cardiac CT allows for measurement of aortic valve area by using planimetry. This is a typical case of rheumatic aortic valve stenosis with a commissural fusion of left and non-coronary cusp with reduced opening. This CT findings is well correlated with measurement of echocardiography. CT-derived aortic valve area correctly correlated highly with MR-derived, echo-derived, and transesophageal echo-derived aortic valve areas. CT planimetry aortic valve areas were significantly larger than transthoracic echocardiography-derived aortic valve area. In addition, agreement between CT and echo in the detection of normal, mild, moderate, severe aortic stenosis was excellent. Accordingly, CT enables accurate, non-invasive assessment of the aortic valve. Continuity equation measurement of aortic valve area by echocardiography is based on the assumption of circular shape of the LVOT that significantly underestimate aortic valve area. On the contrary, CT demonstrate oval shape of LVOT and allow for anatomic aortic valve area using direct planimetry. You can find out the difference between echo aortic valve area and the CT aortic valve area in patients with severe aortic valve stenosis. Aortic valve calcium score difference of LVOT between CT and echo and age are factor affecting the difference in aortic valve area measured with CT and echocardiography in severe aortic valve stenosis in our study. Accordingly, after correcting the continuation with the LVOT area as measured by CT, mean aortic valve area from echo did not differ from CT, and the correlation between CT and echo aortic valve area significantly increased in this study. CT allows for regurgitant orifice area in patients with aortic valve regurgitation. In this study, planimetry measurement of regurgitant orifice using CT was significantly correlated with the degree of aortic valve regurgitation severity as determined by the use of phase contrast MRI. In case of cause prolapse, the valve plan for planimeter of regurgitant orifice should be reconstructed parallel to the regurgitant orifice. The true eccentric regurgitant orifice area was 36 square millimeter in patient with bicos aortic valve with LIPE. Regurgitant fraction by phase contrast MRI was 52%, corresponding to severe degree of aortic valve regurgitation. Cardiac CT accurately detect myocardial fibrosis in patients with aortic valve stenosis. Myocardial fibrosis is an important morphologic substrate of post-operative clinical outcome in patients with severe aortic valve stenosis. Cardiac CT can detect myocardial scar and measure ECV, extracellular volume, like a cardiac MRI. Cardiac CT is able to detect infective endocarditis, vegetation, second aortic valve root wall, abscess, pseudoaneurysm, and the processic valve dehiscency is accurately evaluated by CT. In patients with bicos aortic valve, you can see the vegetation and the failure of coaptation. Cardiac CT has been demonstrated to have a high sensitivity and specificity for detection of valve vegetation and abscess and pseudoaneurysm. 36-year-old man complained of right flank pain. You can see the right renal infarction and the extensive vegetation attached to tissue processes and perivalvular abscess on CT and echocardiography. Cardiac CT accurately evaluate processes valve dysfunction and complication. As you can see, valve thrombus tissue valve thrombus, bioprocess valve degeneration, suture loosening, and pseudoaneurysm, and Panus formation. Distinguishing between Panus and thrombus in patients with process valve dysfunction is essential for selection of proper treatment. Cardiac CT is helpful in differentiating between Panus and thrombus by using cutoff value of hospital unit 145. Cardiac CT is important imaging tool for evaluation of bicuspid aortic valve. Bicuspid aortic valve is the most common congenital cardiac malformation and have various phenotypes according to presence and orientation of cusp and lap. This is bicuspid AP type and CD is RL types. We characterize aortic valve dysfunction and ascending aorta dimension according to bicuspid aortic valve morphology. Patient with bicuspid AP type had higher prevalence of aortic valve regurgitation, large aortic annulus, high prevalence of presence of lape compared with bicuspid aortic valve LA type. This is a case of bicuspid aortic valve AP type. You can see this type accompanied with lape and significant aortic valve regurgitation. But bicuspid LA type is associated with large tubular portion of ascending aorta and severe aortic valve stenosis. Also, bicuspid aortic valve is associated with ascending aorta aneurysm, aortic dissection, and coarctation of aorta. Finally, cardiac CT is a valuable method for evaluation of pre-TAVI evaluation. Cardiac CT play a critical role in patient schedule for transcatheter aortic valve implantation, provide detailed anatomy assessment of aortic annulus, valve, root, left atrium, and left ventricle, as well as coronary artery. This is a reference case for TAVI evaluation with CT, which provide detailed anatomy assessment of aortic valve and the coronary artery and the ascending aorta. Measurement of aortic annulus size is critical for processes sizing in transcatheter aortic valve implantation. For this, CT is used to measure aortic annulus diameter, area, and the circumference during cardiac cycle. In patient schedule for TAVI, as you know, the aortic annulus is smaller in diastole than systole. Please keep in mind multi-imaging approach is necessary for the evaluation of valvular heart disease. Echocardiography demonstrates severe aortic valve stenosis but cannot provide valvular morphology. CT shows bicuspid aortic valve with calcification and coronary artery anomaly. Cardiac MRI shows valvular dysfunction, ascending aorta dilatation, and myocardial fibrosis. In conclusion, cardiac CT provide comprehensive non-invasive evaluation of coronary artery, aortic valve, aortic loop, ascending aorta, as well as pre and post transaortic valve implantation. Thank you for your attention.
Yes, for the last hour presenter, I am very honored to introduce Professor Chen. He is the chairman of the radiologist of the Department of Medical Imaging, National Taiwan University Hospital and Children's Hospital. His specialty are pediatric cardiology and pediatric radiology. His academic appointments are board member of Taiwan Radiological Society and General Secretary General Asian Society of Cardiovascular Imaging. Professor Chen has a lot of papers, more than 160 papers. We don't have much time to introduce all of his papers. But today's his topic is a cardiac CT in pediatric heart disease. Dr. Chen, please.
Cardiovascular imaging. The topic of my presentation is the usefulness of the cardiac CT in the pediatric heart disease. In this presentation, I have nothing to disclose. Cardiovascular CT becomes an essential diagnostic tool in the daily practice due to cutting-edge machines have a markedly improvement in spatial and temporal resolution, ultra-fast data acquisition, and dramatically decrease in radiation dose. For images interpretations, I will show you in the following 8 topics. Let's from the thoracic aortic disease. On your left-hand side is a case of coarctation of aorta with a hypoplastic horizontal arch. Using 3D volume rendering image, you can see a discrete narrowing at the isthmal portion of the arch. Dilated intercostal arteries just distal to this coarctation are noted. The calcified ligamental arteriosis leading to this coarctation is shown in the circle of the small diagram at the lower part. Case on your right-hand side is a Takayasu arteritis. 6-lab maximum intensity projection MIP imaging shows a segmental tapering stenosis at the proximal descending aorta. Another collaterals by way of bilateral internal thoracic arteries are found. Double aortic arch is usually right side dominant. It forms a complete vascular ring that encases the trachea and the esophagus in its center. This case also combined with an AP window, which is very rare. Patent ductus arteriosus PDA is common with different shapes, size, and location of origins, which can be very clearly demonstrated by 3D images of cardiac CT. These 3D images are very useful for planning for transcatheter interventions. Coronary artery disease in adult cardiac CT is a gold standard for non-invasive imaging diagnosis of coronary artery disease. In children, we focus on abnormal or variant anatomies, which may interfere surgical procedures or cause symptoms. In this tetralogy fellow, the left anterior descending coronary artery arises from the proximal RCA, right coronary artery, and run across the RVOT at its proximal segment. Conventional RVOT ventriculotomy to relieve infantile pulmonary stenosis should be prohibited to prevent a disaster of the LAD to be transected. This patient experienced an OCA, out-hospital cardiac arrest. Cardiac CT disclosed an unknown anomalous left coronary artery comes from the pulmonary artery, so-called a kappa diagnosis. This finding explains the patient's event and guides further accurate intervention. Another case of OCA. The left main coronary artery comes from RCA with the elongated proximal segment runs through between the root of the aorta and pulmonary trunk. Such anatomy lets this interarterial segment of the left main coronary artery easily be dynamically compressed and encased by both greater arteries. Pulmonary arterial disease, the most valuable information is to show the severe hypoplastic bilateral native pulmonary arteries and some collaterals in the mediastinum. This color encoding tissue segmentation 3D images can clearly disclose the anatomical relationship between the hypoplastic native pulmonary arteries and its complex network of markers. The native pulmonary arteries are hypoplastic. 3 markers are noted. The first one marker is called M1, arises from the right subclavian artery. The M2 comes from the undersurface of the proximal descending aorta, and the M3 arises from the right lateral portion of the middle descending aorta. This CT image shows a typical presentation of the LPS limb with the tracheal stenosis. 3D image viewing from behind clearly demonstrated the spatial relationship between the encased lower trachea by the LPS limb. Furthermore, please also recognize this congenital tracheal stenosis has a long segment involvement and a lot of narrow part unrelated to this LPS limb vessel. It means reimplantation of the LPA only without tracheoplasty will not relieve patient's dyspnea. Clearly disclosing the pulmonary venous disease is the weakness of the transthoracic echocardiography. Under well contrast medium enhancement in the thoracic cardiovascular structure, cardiac CT can accurately diagnose junctional stenosis of the pulmonary vein into the left atrium. Cardiac CT also can accurately show the full course of every pulmonary veins. In this case of the PAPVR, partial anomalous pulmonary venous return, cardiac CT clearly discloses a sinus venosus ASD with a common association of abnormal right pulmonary veins go into the lateral dorsal wall of the right atrium. The most common form of the supracardiac type PPVR, which drains the venous blood from the left lung upwards by an ascending vertical vein into the left innominal vein. No obstruction is noted. The other pulmonary veins have their normal drainage. This is a cardiac type TAPVR, total anomalous pulmonary venous return, with all of the pulmonary veins drained into the dilated coronary sinus and finally opening into the right atrium. Systemic venous disease, although mostly are asymptomatic, some has clinical implications in either route selections for catheter-based interventions or surgical corrections. This case shows a dense, contrast-enhanced, persistent left side SVC, which has intact wall along the whole course, and finally open to the right atrium. No bridging vein is noted connecting to the right side SVC. This patient also has a hypoplastic arch, small LV, VSD, and ASD. Knowing the disease anatomy and the physiology are both important. On your left-hand side, the upper segment of the persistent left side SVC has a dense contrast median content and the intact outline of the wall. Image on your right-hand side presents the spread of the contrast median in lower left atrium earlier than right atrium. This phenomenon strongly indicates partially unroofing of the coronary sinus. By the way, the contrast jet in trabecular portion of the lower right ventricle on that imaging and a better enhanced RV echo portion than the other part of the RV on right imaging indicates a residual muscular VSD in this repaired truncus arteriosus patient. In this surgical repaired VSD and ASD patient, SVC obstruction is suspected by engorged bilateral jugular veins. Cardiac CT confirms a discrete narrowing at the lower segment of SVC, which is also supported by a jet-like spread of the contrast in the upper part of the right atrium and collaterals around the pulmonary trunk. Complex heart disease. For complex heart disease, cardiac CT is a one-stop imaging study to disclose all anomalies. The most important issue of such an RAI patient is to find the drainage of the pulmonary veins, in particular to check the presence or not of any obstruction in the whole course. From the serial images on your left-hand side, we can clearly trace all of the pulmonary veins going together to a descending vertical veins through the diaphragm downward into the abdominal cavity and finally drains into the portal vein without any stenosis. 3D Volume rendering images of the same patient demonstrate the whole anomaly more vivid. The most impressive one is the infracardiac tap TAPVR that using the descending vertical vein drain into the portal vein without obstruction. The pulmonary trunk is attractive and a large PDA supports pulmonary circulation. By the way, you can see the perfect symmetrical bilateral right atrial appendage locates just laterally to the ventricular outlet on both sides. This case is a tricuspid atresia. The image in the right lower corner shows a deepened right side atrial ventricular group without any connection between the right atrium and the right ventricle. Tricuspid atresia is definitely diagnosed. From 3T and the series sectional imaging, you can see the RV is too small to be used as the competent ventricle. VSD and ASD are also noted. 6-leg MIP imaging, maximum intensity projection, and the 3D volume rendering images on your left-hand side shows parallel arrangement of the greater arteries with the aorta right lateral to the pulmonary trunk. Both great arteries arise from the RV, so DORV, double outlet of the right ventricle, is diagnosed. The most important information for surgical correction is the size and the location of the VSD. Using 6-leg 3D volume imaging on your right-hand side, is disclosed clearly a small restricted VSD just under the subaortic corners, which limited the flow of the blood rerouting from the left ventricle to the aorta. After surgeries or catheter-based interventions, cardiac CT is useful in following up post-operative changes for further dispositions. In this case, the stenotic contegra conduit has eroded into the sternum. Without this critical information, careless sternotomy for conduit replacement may rupture the RVOT and lead to a disaster. A case of transposition of the great artery. After arterial switch operation by a decombed maneuver, cardiac CT is indicated to confirm the suspected bilateral pulmonary stenosis by echocardiography. From both the sectional and the 3D reconstructed imaging, flattened stenosis is noted at the proximal bilateral central pulmonary artery, just straddling over the high pressure aorta. There is also an interarterial course of the left anterior descending coronary artery, which implies the possible dynamic ischemia in the future. After phantom procedures, patients may have systemic to pulmonary collaterals. Cardiac CT could disclose this collateral clearly, especially to identify the origins and the insertions of these collaterals to guide catheter embolization. The last part, cardiac CT, can be very useful to evaluate the implants, device, or other applications. In these patients who receive mechanical valve replacements, cardiac CT can clearly show the motions of this leaflet. On your left-hand side is a case with a limited closure of the leaflets that leads to severe regurgitation. On your right-hand side is a case of limited opening of the leaflets and results in valvular stenosis. In patients diagnosed as endocarditis, cardiac CT was used to check any possible vegetation. On CT image of your left-hand side, there is a crescent filling defect in the lumen of the stented proximal left pulmonary artery. After 5 weeks of antibiotic treatment, cardiac CT on your right-hand side showed a large pseudoaneurysm at the stented left pulmonary artery with contrast median leakage through the stent mesh. Visual aortic innominal vein was an incidental finding. Cardiac CT can provide accurately 3D quantifications of both ventricular volumes and masses, especially of the RV, which its geometry is widely different in every patient. In conclusions, EKG-gated cardiac CT study is very useful in demonstrating structural and functional anomalies in pediatric heart disease. It is non-invasive, operator non-dependent, and can be very easily performed on the outpatient clinics. It is now an important diagnostic tool in the daily assessment. Comprehensive knowledge of cardiac anatomy, physiology, and disease patterns are essential, as well as the patient preparation, scan techniques, contrast administration, and regime dose reductions. Thank you very much for your attention.
Thank you very much, Dr. Chen. He gave an educational lecture regarding the importance of cardiac CT in pediatric cardiology with an excellent image of complex congenital heart disease. Thank you very much.
And his topic is excellent. With the quality topic. Okay, now we have a next discussion. We have about 4 minutes for discussion for the 4th topic. Do you have question for this session? Okay, I have a small question for Dr. Akhilapurata.
Yeah.
The person, what do you think about the PET CTA hybrid for cardiac CT in the future, and now?
The
Yes, CTA.
PET-CT.
Yes, for cardiac.
PET-CT. So
For cardiac CT, for CT angio.
CV.
Nuclear medicine. That's CT.
PET-CT. Sorry. Just
What do you think about this? My idea or speaker? And bad for the function, cardiac function.
Yeah, cardiac function. Now, for the cardiac functional imaging, using CT, the high temporal resolution CT is available now. And now, today I presented the next generation CT for the especially the high resolution CT and the photon counting CT and phase control CT. It is dedicated for the special resolution. Now, there are also CT and the GE high speed country rotation CT is promising for cardiac function.
Okay. But for the CT derived FFR CT, what do you think about this CT FFR? Or myocardial perfusion and function, new vaccine can do better than now in future.
Future?
The FFR.
Dr. Somin, the written the FFR measurement? Yeah, for the like a CT-FFR measurement, and we need a more high spatial resolution for CT, and it is also important for the assessment. I think so.
Okay. And a small question for Professor C.G. Chen. Okay.
Yes.
Which contrast media used for the neurodata for cardiac CT? Contrast media. Contrast media for the cardiac CT in your department. Which contrast media we use?
Conduction.
Contrast media. By example, omnipac or Shilitic for the perfusion.
Perfusion?
Yes.
You mean perfusion? Yes, I think cardiac CT can use a dynamic contrast injection to evaluate myocardial perfusion. But usually in a small kit, because I major in a children's hospital. Those cases want to see the anatomy, and we have less needed to diagnose the myocardial problem like adult. I think for myocardial perfusion will be major applied on coronary artery disease, but in pediatric cases, we use the cardiac CT to clearly demonstrate the structural anomaly, especially by 3D reconstruction. I have a question to ask Professor Kurata.
Yes.
Yes.
Yeah. What's your opinion of the clinical application of phase contrast CT if it is available?
Yeah, it's a difficult question. Thank you. And but now I show some data of the phase contrast CT. The equipment is very complicated and much expensive, and the clinical application is at present is limited, and we can use small. We can use phase contrast CT as like a historical study now.
So phase contrast CT could be in the future perform an in vivo histology level examination, right?
Yeah, I think so.
That's very interesting, and I think we're very promising to let radiology become a pathology.
Yeah. Yeah, thank you. And I have a question to Dr. Saminko. Yeah. You show the value of the cardiac CT in assessment of aortic valvular disease, and in nowadays, we feel the change of the error from the single assessment of echo to the cardiac CT or multi-imaging based assessment of valvular disease. What is important for the clinical if we using CT now?
Thank you very much for your excellent question. As I mentioned in my lecture, cardiac CT has a lot of potential to provide a comprehensive evaluation of coronary artery and the valve and the aorta. Particularly, I want to focus on the valve morphology in patients with severe aortic valve calcification. Bypass aortic valve is very common, but echocardiography has a limitation to identifying valve morphology, particularly bypass aortic valve and the tricuspid valve. And then the other point is to the valve severity in patients with aortic valve stenosis. There is many debate about the usefulness of valvular calcium score, but recently many international society confirmed the valvular calcium score is a valuable tool differentiating between significant and non-significant aortic valve stenosis in patients with a little low ejection fraction. So that is why CT is particularly promising tool for valve morphology and valvular dysfunction in patients with aortic valve stenosis. Furthermore, cardiac CT, as you know, cardiac CT is very valuable for showing coronary artery evaluation before transaortic valve implantation. Yeah.
Thank you very much. And one more question. I have one more question to Dr. Chu. You mentioned about a lot of technique to reduce artifact and image noise. I am always wondering about the heart rate control in clinical practice. Do you have any routine protocol for heart rate control?
Thank you for your nice question. So the heart rate control is very important for us to obtain the diagnostic image quality. So before prior to the scan, we use the nitroglycerin and the beta blocker and the heart rate controlled medication. So it is essential. I think so heart rate control using the medication is the only way to the heart rate control and the arrhythmia. So we need to discuss the cardiologist to control the heart rate and arrhythmia. So I think that this is the only resolution to heart rate control. That's it. Thank you so much.
Yeah. And one more last question to Dr. Chu. Yeah. Do you use deep learning reconstruction in clinical now?
Pardon?
Do you use a deep learning reconstruction?
Contrasted?
Deep learning AI reconstruction.
Reconstruction?
Yeah, in clinical now.
So what is the reconstruction?
Deep learning.
Deep learning?
Yeah.
Deep learning? What is deep learning?
AI.
AI, artificial intelligence?
Artificial intelligence, AI. Yeah. So and now, so some specific vendors provide the deep learning based the algorithm to fidelity from the general GE. So it's a commercial name. It is a commercial name. So deep learning based image reconstruction is from the background of filtered back projection. So the physics is so different from the iterative reconstruction. So GE made this image reconstruction from their big data. So I think I experienced the true fidelity supported by the GE. So I compared the deep learning based algorithm and the iterative reconstruction. So from only my experience, deep learning based image reconstruction is superior to the iterative reconstruction to reduce the image noise. So so CNR, SNR is elevated in my experience. So I think that the further evaluation will be needed for this point.
I have a question to the Dr. Gurata.
Yeah.
Yeah. So you are the pioneer of CT perfusion for showing the physiologic significance of coronary artery disease. So right now is both CT perfusion need more radiation exposure and the contrast media for less than stress perfusion. So that is why recently radiologists and cardiologists are more focused on the CT FFR. But as you know, we have two different CT FFR methods. One is hot floor from United States. The other is machine learning based FFR from Siemens. Yeah. So do you have any experience for using CT FFR using Siemens, or what do you think about, frankly, about the realistic problem of CT FFR? Personally, even though I practice a lot for measurement of CT FFR, but it takes too much time and many disadvantages to show the physiologic data using CT FFR. So what do you think about CT FFR? Yeah. Is it ideal method, or it's too wait? You need to wait a little bit for using CT FFR in real life.
Thank you very much for good question. I have not so much experience, but I saw a few cases of the CT FFR from the heart flow, and as you know, it takes a few hours and a few hours, 7 or 8 hours, and economical cost. The result is very excellent, but preparation is is a disadvantage now because internet connection, the preparation, and connecting the reimbursement or something is a disadvantage. Otherwise, like Siemens or Philips and online on-site based CTFA measurement is a very familiar to us because, for instance, the AI-based Siemens software takes around 20 seconds to analyze the data. Yeah, but this is not clinical based, but it's only clinical research. And now, perhaps you in your country, Korean study team focus on the original software using the CTFA measurement. We can wait the time to use in clinical now. I think so.
Thank you.
Yes, thank you. Now it's time. This session end here. Thank you very much for our co-chairman, all speaker, and attendee. Thank you.
Thank you.
Thank you very much.
Bye. Bye.
Thank you very much, Dr. Chen, Ko, and the Dr.
Thank you.
One day, we can all stay healthy, and no one suffers from hunger. We will only realize this vision together. Together, we will come back stronger. Together, for a future with health for all, hunger for none.
My journey continues, and I know I'm not alone. Because together we can make a difference every day.